Thanks very much, Elizabeth. And thanks again, Serge, for the invitation to speak. So I'm going to deal with this subject, and I'm going to start off by showing you an arrow of kind of the trajectory of the life history of a patient with PV and ET, and the issues, of course, that we've alluded to include thrombosis or hemorrhage, long-term issues of progression to myelofibrosis or acute myeloid leukemia, and of course the issue of overall survival. And the question at hand for this presentation is, what do we know about cytogenetic and molecular abnormalities in these conditions, and what impact do they have on these long-term endpoints in these two conditions? The other issue, of course, that we deal with these patients that are as important include the issues of splenomegaly, perhaps not so much with PV and ET compared to myelofibrosis, but in a handful, this can be an issue. Of course, hematologic control, and I think most importantly, symptoms and quality of life. Now, you've seen this risk-adapted therapy algorithm for how we address treatment options for PV and ET patients. And again, if you're low-risk PV, that is age less than 60 and no history of thrombosis, low-dose aspirin phlebotomy is standard of care for high-risk PV patients, either having advanced age or a history of thrombosis. You add a cytoreductive drug with hydrea generally being considered first line. Essential thrombocythemia, the same type of treatment perspective, low-risk patients just aspirin, and high-risk patients addition of a cytoreductive. And we alluded to the issue of patients with high platelet counts. They are at risk for bleeding, and those patients, it's worthwhile getting a VWD panel to seeing they have an acquired von Willebrand defect, in which case one needs to be very judicious about the use of aspirin and consider holding it if they are having bruising or bleeding. So let's talk about JAK2 V617F and what are the clinical phenotypes associated with allele burdens. And this was data that was presented now several years ago. And we know that in PV, with the higher allele burden, that is associated with increasing red blood cell mass, increasing white blood cell count, but also actually decreasing platelet count. And when you're looking at two tiers, that is a higher tier allele burden, 75 to 100% versus the lower tier, 1 to 25%, you see that in patients with higher tier allele burdens, these are patients that have more commonly splenomegaly, require chemotherapy or cytoreduction, and experience a major cardiovascular event. Now, in ET patients, when you're looking at just a binary issue, whether the patients are JAK2 positive or negative, you can see that in patients with ET that have a higher hemoglobin but do not meet criteria for PV, that the JAK2 mutation is associated with a higher hemoglobin, elevated white blood cell count, but again, a lower platelet count. Now, one study that came out several years ago is this issue of JAK2 allele burden in PV, and what does it mean in terms of progression to myelofibrosis, and this certainly relates to one of the questions that was in the audience survey at the start of the session. And you can see that in this prospective study of patients, that those patients that had a allele burden that was greater than 50% versus less than 50%, one experiences a higher rate of progression to post-PV myelofibrosis. Now, Ilutaferi and colleagues did a large analysis of the factors that are important for various aspects of PV, including survival. And the one item I want to bring up is this issue of abnormal karyotype. And you can see that among 630 patients that were evaluable for cytogenetic analysis, 12% of patients had an abnormal karyotype. And you can see, in addition to the issues of advanced age and leukocytosis and venous thrombosis, another risk factor that came out in the multivariate analysis as being important for overall survival is this issue of having an abnormal karyotype. And so the question, of course, comes to mind is, should we be performing bone marrow biopsies to capture the 10 to 20% of PV patients with an abnormal karyotype to better inform prognosis? So perhaps by a show of hands, it would be worthwhile seeing amongst the audience here, in your patients who basically have high clinical suspicion for PV or made a diagnosis of PV based on clinical and laboratory parameters and mutation analysis, how many of you will in fact proceed to do a bone marrow biopsy? So it's really a minority. I actually have to say that the overwhelming majority of patients, I do not do a bone marrow, but with this data, I am thinking about reevaluating my practice. I will also say that when one interacts with our European colleagues, the idea of doing a bone marrow biopsy seems to be heretical. Not doing a bone marrow biopsy seems to be heretical. So this is perhaps a point for further discussion. So another scoring system that is used is the International Prognostic Scoring System for Thrombosis in ET, or IPSET. And you can see the risk factors that are used to generate 3 tiers of risk for developing thrombosis. They include an age greater than 60, cardiovascular risk factors, history of previous thrombosis, and the JAK2 V617F mutation. And you can see the hazard ratios and scores that are assigned to each of those risk factors. And again, you can see that for patients with a low-risk category, the total score is 0 or 1. The annual risk is of about 1%. You get a score of 2. Intermediate, your risk of getting thrombosis over 1 year is around 2.5%. And in the high-risk category, it goes up to almost 4%. And an analysis was done by Passamonte in the Italian group, and then showed that when looking at the CALR mutation in a multivariate analysis with these risk factors, it actually does not modify the IPSET score for predicting risk of thrombosis ET. Now, that's a good segue to discuss the CALR mutation. This was a mutation that was discovered, or I should say published, in December 2013 by 2 groups with multiple collaborators. And you can see the double-headed figure here, and that's meant to show that there are different clinical and laboratory features in these patients. Most notably, in patients with JAK2 who have ET, you tend to have a higher thrombotic risk. And in patients who have CALR mutated ET, the platelet count tends to be higher. And thirdly, in patients who have JAK2 mutated ET, you tend to have an elevated hemoglobin and leukocyte count compared to CALR mutated ET. In the upper right-hand panel, you can see that, at least in this publication, that survival was longer in patients with CALR mutated ET versus JAK2 mutated ET, and the p-value was 0.04. Perhaps more significant is the fact that amongst ET patients, if one had a JAK2 mutation, the rates of thrombosis was clearly higher than if one had CALR mutated ET. Now, I'm going to go back to this issue of survival in ET and CALR versus JAK2 mutation status because this issue of prolonged survival, at least found in this New England Journal of Medicine study, was not reproducible in other studies, and I'll show you some of the graphs from those studies. And this was a study by the Italian group and collaborators, and it just basically shows that when you're looking at patients with CALR mutated ET versus JAK2 mutated ET versus JAK2 mutated PV, which of course is almost 100% of patients, you can see that if you have a JAK2 mutated ET or JAK2 mutated PV, that the hemoglobin levels are higher. You can see that the EPA levels are lower in JAK2 mutated ET or PV. The white blood cell count tends to be higher, again, in those patients with PV or ET with JAK2. But the platelet count, again, is higher if you have CALR mutated ET versus JAK2 mutated ET or PV. And looking at Kaplan-Meier curves for various long-term endpoints, in terms of patients with ET, there is no evolution to PV if you have the CALR mutation, but if you have the JAK2 mutation in ET, there is a certain evolution rate from ET evolving into PV over time. Thrombotic events, again, were higher if you had JAK2 mutated ET versus CALR mutated ET, whereas the rates of transformation to myelofibrosis or to acute leukemia were not different between CALR and JAK2 mutated ET. Again, this will hopefully answer some of that question that preceded my talk. This is another study, again, confirming this issue that thrombosis rates are higher in JAK2 mutated ET versus CALR mutated ET. It's shown here a little bit differently. This is thrombosis-free survival, and again, you see the CALR curve on top there. And overall survival, again, you have the no significant difference actually in this study between CALR and JAK2 mutated ET, in contrast to the NEGM study. And then finally, regarding this issue of survival of JAK2 versus CALR mutated ET, the study by Ailu and also Alessandro Vanucci and his Italian colleague showed that the survival of CALR mutated ET is about 19.7 years, and for JAK2 mutated ET about 19 years. Again, no significant difference in survival in ET patients if you have JAK2 versus the CALR mutation. Now let's move on and just discuss again this issue of mutations and response to therapy. And again, this was a slide that Dr. Rapal showed earlier. And basically, the take-home message from this is that the quality of the responses tend to be better if one does not have TET2 mutations present. And also, the amount of JAK2 allele burden tends to be better if a TET2 mutation is present. And so you can see, although I don't have a pointer, those red boxes tend to segregate in patients that don't have a complete molecular response, but those that tend to have less quality molecular responses, partial molecular or major molecular or no response at all. So having these non-JAK2 mutations appear to have some form of resistance, at least to this particular form of therapy in the guise of pegylated interferon alpha-2A. Now, another interesting study that was published in the New England Journal of Medicine is from the Johns Hopkins group led by Jerry Spivak and colleagues. And basically what they did is they took CD34 cells that were circulating in the peripheral blood of patients with PV, and they did gene microarrays, and they were actually able to classify in 19 patients, granted it's a small study number, patients that had a signature for indolent disease and patients that had a relatively more aggressive phenotype, that is higher frequency or earlier transformation to myelofibrosis or acute leukemia. And the signature was independent of some historical markers that we would use, including white blood cell count or platelet count, and it was independent of JAK2 allele burden. But I think that from a practical standpoint, I don't see us anytime soon performing gene microarrays in our clinical lab to inform what we're going to do about our PV patients. I suspect we'll default back to our typical risk-adapted therapy guidelines in terms of age and prior history of thrombosis. Now, this is another interesting study that was published by Anthony Green and colleagues in the New England Journal of Medicine earlier this year. And this goes to the issue of doing single-cell colony assays and looking at the order of acquisition of mutations in patients with MPNs. And you can actually look at these colonies and see if the TET2 mutation is present only, whether a JAK2 mutation is present only, or whether TET2 and JAK2 mutation exist in the same colonies, which arise from a single cell. And the take-home message from this study, again, was that if you have a TET2 mutation first, this seems to restrain the proliferation that's associated with a JAK2 mutation. So TET2 mutated patients, that is, patients who have the TET2 mutation arising before the JAK2 mutation, generally an older age of diagnosis, they had a lower risk of thrombosis, and they had a relative expansion of their CMPs, which is the myeloid progenitor cells, in contrast to expansion of the megakaryocyte erythroid progenitors that would, of course, give rise to perhaps exuberant proliferation of red blood cells and platelets. In contrast, if the JAK2 mutation was first, these were patients that were generally younger at diagnosis. They did have more expansion of their megakaryocyte erythroid progenitors, in keeping with the phenotype of PV. They did have an elevated risk of thrombosis, and again, a higher probability of having PV versus an ET phenotype. So what is a potential algorithm that we can use in incorporating molecular status? This is at least one algorithm. It's by no means the definitive algorithm that was published by Ailu and Dr. Barboui earlier this year in the American Journal of Hematology. So for patients that have very low-risk disease, that has no history of thrombosis, younger age, They're JAK2 V617F unmutated, and that, of course, would pertain mostly to ET patients. These are patients that they would recommend observation alone. However, if patients had low risk but not very low risk disease, that is, no history of thrombosis in younger age, and they had the JAK2 mutation or cardiovascular risk factors present, they would consider the use of once daily aspirin with the presence of the JAK2 mutation or cardiovascular risk factors. If you have both, well, they would consider using twice daily aspirin. I really don't know any specific data to suggest that this is necessarily the right way to go. I don't think it's necessarily evidence-based, but that is a consideration. For patients with high-risk disease, no thrombosis history, hydrea, and once daily aspirin, and then you can see the other options there for history of thrombosis, arterial versus venous, and also other considerations in terms of age, JAK2 status, and cardiovascular risk factors. The use of hydrea plus daily aspirin, and then hydrea plus anticoagulation if a venous thrombosis is actually present. So I'm just going to end by making some basic summary points. The first is that PV and ET, in my opinion, are generally molecularly bland compared to the heterogeneous genetic landscape of myelofibrosis. The discovery of the Karyotype mutation highlights subgroups of ET patients that have distinct hematologic profiles and thrombosis risk compared to JAK2 mutated ET. In this current year, there's really modest use of molecular data for molecular prognostication of PV and ET. We do know that the JAK2 mutation is incorporated in the IPSET system. And perhaps next-generation sequencing, or NGS, may be useful to predict or explain suboptimal responses to certain therapies, such as interferon alpha. And I do have to question the practical utility of abnormal karyotype JAK2 allele burden and gene signatures in PV, but I think if any of those are something that I would gravitate to, it would be doing bone marrows and looking for an abnormal karyotype to inform our patients about whether their prognosis may be changed by the finding of cytogenetic abnormalities. So I'll leave it there, and I thank you very much for your attention.